Our sixth objective, understand that all MGD is not obvious. 100% of it is not obvious prior to the cascade. And after the cascade, when symptoms start kicking in, it still usually is not obvious, because you can have all the burning that you had on a constant basis before the anatomical changes start. And that's so critically important to understand. And this was published again in Cornea several years ago. Now, the way we were trained was to think that's somebody with meibomitis. That's an individual with meibomitis, with really gross, frank, obese signs. And maybe if you look subtly, you could see a little bit of notching and irregular lid margins. So the more sophisticated person would say, well, you know, there's lid changes. But you can look at a lid that's absolutely perfectly clean, and you can apply all the mechanical pressure in the world, and there won't be one iota of material, of secretion, of pre-secretion, of inspissated material that will come out. So we have to understand that. And these, as I was talking with Dr. Lewis, are slides that were taken actually in 1977. That shows an individual who has a perfectly clean-looking lid. There's no blepharitis, there's no telangiectasia, there's no powdering, there's no sign. Appears perfectly normal, yet no matter how much pressure you apply, nothing comes out. Zero comes out. And the reason can be what you see in this histological section, namely that you have total obstruction of the terminal duct of that gland, and then behind it you have a dilated duct. Write down dilated ducts, because dilated ducts are something that you'll be seeing with transillumination and are critical. And when you have a dilated duct, that means that the gland is not functional. It cannot be functional if that duct is really dilated. So if we're going to summarize non-obvious obstructed MGD, it is the most common form of MGD. Now, MGD is the most common form of all dry eye as the root cause, but non-obvious MGD is the most common form of evaporative dry and dry eye. And lids and MG orifices, they may appear normal without all of these classical signs, but the Meibomian glands may not be functional, and the only way you can diagnose that is either with pressure by determining whether or not the gland is or is not functional.